Raji Hadijat. She'll be taking us on the basic principles of gestational age assessments. Professor Raji Hadijat is a professor of obstetrics and gynecology with special interest in fetal maternal medicine. She's a trainer and has trained many resident doctors. She's got an MSc in prenatal genetics and fetal medicine from the prestigious University College, London. I can go on and on introducing this great woman. It's a privilege for us to have our great teacher here with us, Professor Hadijat Raji. Welcome, ma.
Good evening, everyone.
Thank you very much. Good evening,
I'm glad to be here. And thanks for that very generous introduction.
Generous, I just bridged it all. Thank you very much, ma. You're welcome.
Yeah, so I'll go ahead and share my screen.
Yes, ma.
Once again, I'm glad to be here. I'm going to be talking about principles of gestational age assessment. And quite a number of what I'm going to say has been already said by Charles. So we've glossed over those areas so that we save time. We've lost some time already. So I'm assuming that we're all healthcare workers here. True or false?
True.
Yes, and we're all obstetric care providers. Yeah. Yes. Okay. And we're all obstetric care providers. So this lecture, there are lots of things that you would have heard before. So we'll just be reminding ourselves about some things, and maybe you also learn some new things as well.
And on meeting online.
So the aim of this lecture is to emphasize the importance of accurate determination of gestational age, and also highlight the different methods that we have of estimating gestational age, as well as the limitations that these methods could have. So what is gestational age? It's the same thing as menstrual age, which is the time since the menstrual cycle. Note that this is different from conceptual age because the menses comes before ovulation. So the conceptual age is about 2 weeks younger or earlier than the menstrual age. And estimating gestational age is like the foundation of anything that we do in obstetrics. There's nothing you can do without knowing what the gestational age is. If you don't know it, then it's going to impact on your management of that patient in so many different ways. I should have asked you this question, but because we've lost a lot of time, I'm just going to go ahead and answer it myself. I'm sure we all know the answers. Why do we need to estimate gestational age? We already talked about the first one, that is the foundation of all decisions that we make in obstetrics, okay? It helps us to determine whether the fetus is viable or not, because if you're not seeing a heartbeat when you should be seeing one, then you know that there's a problem. And that can also help us in prognosticating the outcome, counseling our patients about the possibility or the possible outcomes for that pregnancy. It helps us to time investigations. For example, we want to do thermal screening for chromosomal anomalies, or want to commence the antenatal surveillance. We need to know what age the fetus is so that we know what structures we're expecting to see. If we also want to do an anomaly scan, we need to have an idea of what the gestational age is, so that when we pick an anomaly, we can interpret and counsel the patient appropriately. You want to do your invasive procedures like amniocentesis and chorionic villus sampling, we need to have an idea of what the GA is. And also timing of therapy. You're thinking, okay, is this a preterm baby or not? Do I need to give steroids? Is the lungs mature? We definitely need to know whether what the GA is. And of course, also inserting a sacrilege and removing the sacrilege. You have to know what the GA is. It helps us to also plan obstetric management. For example, we want to deliver. When do we deliver? Are we going to wait until term? Are we going to deliver preterm? Where are we going to deliver? Is this pregnancy term and can be delivered in any healthcare center? Is it a preterm baby and we think the baby is going to need neonatal intensive care, such that we need to refer, preferably in utero, to the next facility that has an NICU facilities? All these things, all these decisions are impacted upon by our assessment of the gestational age of the fetus. Now, it's been found that when you're not sure of the GA, there's so many things that can go wrong. It's been associated with adverse prenatal outcomes, irrespective of the characteristics of the mother. And appropriate dating helps us to decrease iatrogenic prematurity. I don't know if anybody or if any one of us has ever experienced having to bring out a preterm baby just because we were not sure of the dating and there wasn't any early ultrasound done. And so the late ultrasound is not so accurate in terms of the accuracy of the scan. And that can actually lead to iatrogenic prematurity. When you date appropriately, you also reduce the risk of unwarranted induction of labor for an assumed postpartum pregnancy. It helps us to also guides our decision making when we're thinking about termination of pregnancy and also decisions on appropriate place or timing of delivery. So what factors affect our determination of gestational age? First, from the history, menstrual history, conception history. Menstrual history meaning the first day of the last menstrual period. But this can be affected by how regular that menstrual period is. Does this woman have a 28-day cycle? Does she have a 32-day cycle? Is the cycle irregularly irregular or regularly irregular? All this will affect our estimation of gestational age from the last menstrual period. The ovulation history is also important, though we're saying that for a woman that has a 28-day cycle, it is assumed that she ovulates on the 14th. But who says she will not ovulate on the 15th or the 13th? All right. Some men also bleed in early pregnancy, and that can affect their your determination of the accurate last menstrual period because that bleeding can actually confuse them. From your physical examination, you can actually use the physical examination to try and have a rough estimate of the gestational age. For example, measuring the fundal height. But that can also be affected by so many things: maternal obesity, coexisting uterine myomas, multiple gestation, abnormal lipo. All that will affect your determination of the gestational age using the physical examination. And then, of course, we have the ultrasound estimation of fetal gestational age, which depends on what trimester you're doing the ultrasound, what is the scale of this person doing the ultrasound, which biometry you're using to measure the baby, and also whether you experience any technical difficulty while doing the scan. So this is just a review of those methods that we use for assessing gestational age. History, that's from the woman's last menstrual period, and some other history that we'll talk about shortly, physical examination, and then ultrasound finding. From the history, okay, we said we use the first day of the last menstrual period, that's Naegele's rule. This assumes that the woman has a regular 28-day cycle and that she ovulated on the 14th. I've already said this is not so all the time. We can take a history of quickening from the woman to give us a rough idea of what the age of the pregnancy is. For IVF pregnancy, of course, that makes it easier because you know the conception date is actually known. Use of oral contraceptive pills can affect the length of the menstrual cycle and also affects our accurate determination of G from the history. Another thing that can affect it is recall, poor recall. It said that in up to 45% of women, there's a poor recall of the last menstrual period. And I'm sure a lot of us have had the situation where you have the couple in your consulting room and you're asking the woman, when was the last menstrual period? And she looks at her husband, expecting the husband to give the response. And sometimes the husband may actually be more accurate because he may write it down. So this just buttresses the fact that women actually have poor recall. And when they have poor recall, they may not volunteer that their recall is poor. They just give you a digit. And it's been found, studies have found that women actually have some bias for some days of the month. It's also important to know that we have a varying length of follicular phase. And also, we're not sure of the exact survival of the sperm within the reproductive tract. So even if the woman ovulates on the 14th, you're not sure where exactly conception occurred. It's instead that when you date pregnancies from last menstrual period, you have a higher prevalence of postpartum pregnancies.
Yeah, how far?
Hello, can you hear me?
Yeah, how far?
Oh, okay, all right. Yes. Studies have also found that only 4% of men deliver on their expected date of delivery due to different factors. Variation in human gestational length. We're not sure exactly what the gestational length is. Remember that this term that we talk about, being 37 to 42 completed weeks, was done based on studies that I'm sure did not include Nigerians. So how do you know that we have the same gestational length as Caucasians and all that? There's also a natural biological variation in fetal maturation, and so that will also influence the timing of spontaneous onset of labor and vaginal delivery. Physical examination can help you to estimate the GA either by the manual examination or the fundal height, or using the time that fetal heart tones are first picked. Usually from 20 weeks and above, you can estimate your fetal gestational age using the fundal measurement. But this has an error margin of 4 to 6 weeks. Remember that by the time the man is 42 weeks, when you examine her abdomen, it could still be 36 weeks in fundal height. So that is a big limitation. Auscultation, if you pick the fetal heart tones, usually is picked with the sonic aid earlier, and then with the penile stethoscopes, usually around 20 weeks and above is when you first expect to pick it. Since fundal height measurement was also suggested in a Caucasian population, so we're not really sure whether we have any differences in the African population, and also whether there's a difference in this based on change in diet, change in growth, and all that, because this was first suggested in 1906, and we're now in 2025. So you can see that I'm not sure there has been any other study carried out of recent to look at this and see whether there's any changes based on so many other things that have changed between that time and now in 2025. So the fundal height assessment is affected by maternal habitus. I talked about that earlier, multiple gestation, fetal lie, liquor abnormalities, and also inter and intra-observer differences. And of course, most of us also don't bother using the tape measure when we're measuring. We just estimate using our finger breadth. And I'm not sure if we all actually have measured our fingers to be sure exactly. We just assume it's 2 cm per finger. But how do you know your fingers are not less than 2 or more than? So this slide is just looking at how we can use the accuracy of clinical predictors of GA. I can see that IVF has the highest accuracy with an accuracy of give or take 1 day. And then the fundal height after 32 weeks has an accuracy of 4 to 6 weeks. So that's very, very huge and can affect your management of the pregnancy. So because most pregnancies are not IVF pregnancies, that means that we need to have a way to accurately establish what the gestational age of the woman is. And that's why we now are where we are here today, learning about ultrasound, which is something that has changed practice since it started. In those days, you had, it wasn't so easily accessible or affordable, but now you can't even imagine having a pregnancy without any scan. In fact, before the woman comes to you to book, she should have had 2 or 3 scans. And by the time she's coming, she's telling you that, oh, these are the scans I've done even before booking. Okay, skip this, yes. So ultrasound is very useful for early pregnancy dating. And in the early pregnancy, what are you interested in? Usually the structures that are interrogated are the mean sac diameter and then the Crown-Rump Length in early pregnancy. And then as pregnancy advances, we move on to the other parameters like the Biparietal Diameter, the head circumference, abdominal circumference, and femur length. These measurements can be taken via the transabdominal scan or transvaginal scan. Remember, we're talking about early pregnancy. So in early pregnancy, you can actually use the transvaginal scan to determine the mean sac diameter or the Crown-Rump Length. These structures are what you expect to see in the first trimester, either by your transabdominal or transvaginal scan: the gestational sac, the yolk sac, the embryo, and the fetal cardiac activity. And you're also expected to measure the mean sac diameter usually. The first trimester is said to be the most accurate period for assessing gestational age. Why? Because in that first trimester, you have the minimal variation in fetal size. And you can also see the fetus in its entirety. That's from the crown to from the tip of the crown to the rump. So you're seeing the image of the fetus completely in one view. Unlike in more advanced gestation, where you take different measurements, you measure the biparietal diameter separately, the abdominal circumference separately, and then you input all that into the software that gives you the that computes the gestational age. So the gestational sac is the first thing that you see. It's the first sign that there's actually an intrauterine gestation. And Charles already talked about being sure that this gestational sac is actually intrauterine, so that I can exclude an extrauterine pregnancy. It is visible from 4 weeks and above using your transvaginal ultrasound, and from 5 weeks and above using the transabdominal scan. And the accuracy for your gestational sac assessment of GA is plus or minus 1 week. Usually when you identify the sac and freeze your image, you measure from the inside of the hyperechoic rim, inner to inner. In the longitudinal plane, you measure the long axis and the AP measurement, and then you turn your probe 90 degrees and measure the transverse plane. And the mean sac diameter is calculated by averaging these three measurements. Although we measure the gestational sac diameter, we actually don't use this. It's not reliable as a dating method for pregnancy. We also need to be aware of the pseudo-gestational sac, which you can see when you have an extrauterine pregnancy. Okay, and I have an image here that is showing us the pseudo-gestational sac. The real gestational sac has the double decidual sign. Oops, am I the one making this red mark? I don't think so. Somebody is making a red mark on the screen. So this is the normal gestational sac with a double decidual ring, unlike the pseudo sac that only has one ring. So that's how you can differentiate an intrauterine gestation from a pseudo gestational sac. So I've mentioned this already. Even though we can measure the gestational sac and the mean sac diameter, we don't use it for dating the pregnancy or assigning EED. It's only useful to try to see whether the fetus is viable or not. The yolk sac is also seen in the first trimester as early as 5 weeks, and you can actually identify it up to 11 to 12 weeks. It is also not used to determine the gestational age of the fetus. Now, the Crown-Rump length is the most reliable, most accurate method for dating a pregnancy. And it's used in the first trimester. It's said to accurately date pregnancies between 7 to 13 weeks gestation with an accuracy of plus or minus 5 to 7 days. After 12 weeks gestation, the accuracy is reduced. So you move on to use other parameters like the head circumference. Charles already talked about some of this. When you want to measure the Crown-Rump length, you measure the longest axis with the fetus at rest, not too flexed, not too extended. You need to have some fluid between the chin and the chest of the fetus. I measure from the tip of the cephalic pole to the tip of the caudal pole, making sure that you do not include the lower limbs or any yolk sac in your measurement. And this is showing us the ISO practice guidelines for CRL measurement. You can see first you have to have a midline sagittal section of the whole embryo fetus. You have to optimize your image. You're going to be learning more about that as this course progresses. The image should be oriented horizontally and should fill most of your screen, more than 3/4 if possible of your screen, with the fetus in a neutral position, neither too flexed nor hyperextended. And then you take your measurements from the tip of the crown to the rump. This is just showing us an ultrasound image showing the Crown-Rump length measurement. This is actually, we like to call it a reverse image. Usually they have the head on the opposite side of the screen. Now, this image is showing us the same fetus. In one of the fetuses, in the picture on the left, this fetus is overflexed, okay? Because it's overflexed, the measurement they're going to get is going to be a smaller measurement, which will give you a smaller estimated gestational age. The fetus on the right is still the same fetus, is now in the neutral position, and you're having a Crown-Rump length of 62 millimeters, which gives us 12 weeks plus 4 days. So you can see that just because of excessive flexion, you have a difference of 1 week between these fetuses. And that can be quite significant when you're talking about pregnancy outcome. So it's important to learn the correct way of getting the right images and the correct way of taking our measurements so that we get accurate measurements and date our pregnancies appropriately. So we'll move on to the second and third trimester. From the second trimester, from the 12 weeks of pregnancy, actually, you can use the biparietal diameter. And this can be used right from the 12 weeks up to the end of the pregnancy. And then subsequently, we have the head circumference, the abdominal circumference, and the femur length as the common parameters that are used. Now, for the third trimester scan, we should know that the third trimester scan is not as accurate as the first or the second trimester ultrasound, because we have increasing biological variation as the gestational age increases. At the same time, if that fetus will have growth anomalies, this is likely to be more obvious in the third trimester. That's when you have your growth restriction or your fetal macrosomia being picked up. At the same time, don't forget that disparity in the accuracy of the third trimester scan which is plus or minus 3 weeks. So that means that when you're doing your third trimester ultrasound, and your ultrasound is telling you this fetus is 36 weeks, the fetus can be anywhere from 33 weeks to 39 weeks. And that's a huge, huge difference. So biparietal diameter, Charles has talked about this, measured in a cross-sectional view. You can use the level of the thalami. Accuracy depends on the GA. The less the GA, the more accurate. So when you're doing it in the second trimester, it gives an accuracy of less than 2 weeks. In the third trimester, accuracy becomes plus or minus 3 weeks. And the sonographic landmarks for the correct BPD plane, you expect to see the midline forks, the thalami, symmetrical appearance of both cerebral hemispheres, cavum septum pellucidum, and you do not expect to see any cerebellum in your view. And this is just showing us the schematic diagram of the BPD view. Okay, so that's the view you expect at the widest part of the head. And these are the structures that you see: the cavum septum pellucidum, the thalami in the middle, the oval-shaped skull bone. And then you place your calipers from outer to inner at the level of the thalami, where the head is widest. And you make sure that your calipers are perpendicular to the forks, so they should be at 90 degrees to the forks, the midline forks. Limitation of measurements with the BPD is that it can be affected by the shape of the fetal head. For example, if the fetal head is elongated, it leads to an underestimation of the BPD. If it's unusually rounded, that's brachycephaly, it leads to an overestimation. At the same time, if the fetus is engaged, then it can actually make it difficult for you to get an accurate biparietal diameter.
Prof Ma, you've got 10 minutes more.
All right. So if you're not sure, for example, you think the head is overly rounded or overly broad or something, you can actually measure the head circumference, which is less likely to be affected by the shape of the fetal head, and usually measured using the ellipse method from outer, and you place your calipers from outer to outer without including the scalp. And then the abdominal circumference measurement measured on the transverse section of the upper fetal abdomen is actually less accurate than the head measurement, but it is the parameter that is most useful when you're monitoring the growth of the fetus. Usually you use the ellipse method and you take your measurements at the outermost aspects of the fetal soft tissue. And accuracy, like all the other methods, decreases as gestational age advances. I think Charles talked about this as well. I'm sure you're going to be learning about more of this when you have your hands-on sessions. Okay. Like I said, abdominal circumference is most affected by the growth. So it's actually very key when you're monitoring for growth restriction or suspecting there's fetal macrosomia. It can also be affected by biological variations and also technical factors. And at the same time, its accuracy decreases the closer you are to term. Femur length. The femur is the largest long bone, supposed to be the easiest to measure. It's the least movable. I can view it from 14 weeks until delivery. Just like all the other parameters, as gestational age advances, the accuracy reduces. And this is showing us the correct plane for the femur length measurement. Can also be affected by biological variations, technical factors, and sometimes when there's anomaly, fetal anomalies, like if you have achondroplasia, you have short, long bones. The long bones in quotes are shorter than they should be. And you can have a pointer to that, or you can suspect that when you have your BPD and your AC having similar, giving you similar gestational ages, and then you have your femur length being out very, very small compared to the BPD and the AC. Of course, you need to be sure that you're not measuring the humerus, and that you can only know when you're doing your ultrasound by following the fetus and being sure that you're imaging the femur and not the humerus. And the bladder has been mentioned as one of the landmarks to know where the femur is. So sometimes you have discrepancy in some of your measurements. It can be a false discrepancy because of measurement errors. So you need to look at your section again and look at your caliper placement. But there could also be a genuine discrepancy. For example, we talked about achondroplasia, in which you have small femur length compared to the others. Sometimes when you have asymmetric growth restriction too, you can have the BPD being preserved, whereas you have the femur length and the AC being smaller than you're expecting them to be. You could also have large abdominal circumference when you have fetal macrosomia. The transcerebral diameter is also a measurement that can be taken and is useful when you're trying to date a pregnancy. It's not routinely done usually, but it can be useful, particularly when you're suspecting there's some growth restriction. It is not affected by differences in the shape of the head, and it has been found to correlate well with other parameters, particularly in the third trimester. So what is the best parameter for estimating gestational age? Can anybody help me with that? Oops. What is the best parameter? Let me see. I can see and Dr. Awarute Flebo. Can you help us out? Febo, is that Febo? Febo. What is the best parameter for estimating gestational age of the fetus? Patricia Obaweki, can you help us out? What do you think is the best parameter? Patricia? Now I feel as if I'm talking to myself.
Please, participants,
yes.
It appears some of us just log in and we're not here. If you're present here, just put up a hand, as in raise your hand in the chat box.
Yeah, I can see Patricia, though she didn't put on her light, but I can still see her.
So participants here, please indicate by raising up your hand on the chat.
And somebody just volunteer. What's the best parameter? What do you think is the best parameter? Our time is almost up, so we don't waste so much time. Anybody?
I'm with it. Good evening. CRL.
The CRL, okay?
Yes.
Okay, so what if you want to measure in the third trimester?
BPD will be very good.
BPD femoral length. Or femoral length. So we are all saying different things, and we're all right, because the best parameter depends on different things. Depends on the timing of your measurement. If you're doing an early pregnancy scan, the CRL becomes the best parameter. Okay, in the second trimester, the BPD becomes better. But generally, sometimes, you remember we talked about sometimes having a disparity between some of the parameters. So you also need to keep that in mind. And the combination of parameters will actually give you a better dating. In the second and the third trimester, a combination of biometric parameters is actually more accurate. But if you're seeing the woman early, the CRL is the most accurate parameter for dating. But remember, most of our women don't come in early. So we will have lost that opportunity to date the pregnancy using the Crown-Rump Length. So in the second and third trimester, use of multiple parameters gives us improved accuracy. As much as possible, you don't want to use the third trimester scan to date a pregnancy, if possible. So that should be the absolute last resort. In that unusual woman that has never had any scan done, and you're saying for the first time during the pregnancy and the third trimester, then you can have a third trimester baseline scan, and then you now follow up with follow-up scans so that you can compare the fetal growth and use that to estimate the gestational age. But this should not be a routine. So use of multiple parameters improves the accuracy. We have various formulas, which is embedded in the ultrasound machine. And you should be careful when you have abnormalities. For example, when you have macrosomia, you may need to take the AC out of your calculation. Remember, the formula usually have a combination of BPD, HC, AC, and FL. But if you already know that the AC is above the 90th center, you're thinking there's fetal macrosomia, that means that you take the AC out of that calculation, and the G is calculated based on just the BPD, HC, and FL. The same way, if you have skeletal dysplasia, you take the FL out of the calculation. If you have hydrocephalus, you can take the BPD and the HC out of the calculation. So generally speaking, accuracy of your ultrasound estimation of GA varies with the trimester of pregnancy. In the first trimester, plus or minus 5 to 7 days. Second trimester, plus or minus 2 weeks. And then the third trimester, plus or minus 3 weeks. Multiple pregnancy is a dilemma, but you can still use your ultrasound to accurately date the pregnancy. It's also very useful when you're trying to see whether there's any discordance in the growth of the fetuses. And it's been said that usually the growth charts that are used for singletons can also be used for multiple gestation, up to 30 weeks of gestation. But after then, it's said that maybe your femur length may actually be more reliable in dating a twin gestation. So sometimes we need to reassign the gestational age of dating based on our ultrasound. So the teaching is that when you have a first trimester ultrasound and you have the woman giving you her last menstrual period, you have calculated her gestational age from the last menstrual period, and you also have a first trimester ultrasound. You compare. If the difference between that dating with the LMP and dating of your ultrasound is less than 5 days, then you can retain the dates from the LMP. But if the difference is more than 5 days, then it's better to stick to the dates from the ultrasound estimation of gestational age. The second trimester, if you have a difference less than 7 days with that of the LMP, then you can accept the date from the LMP. And if the difference is more than 7 days, then it's better to stick to the ultrasound-derived gestational age, that's in the second trimester. And like I said, usually, generally speaking, third trimester scan should not be used ideally to date a pregnancy. Ultrasound sounds very good, but it has its limitations. Sometimes you have some technical difficulty. It may be difficult to obtain your proper axis for measurement. Sometimes the fetus is moving, does not stay in one place. The maternal habitus may not be conducive to getting the best images. The fetal position may also affect your images. The type of machine that you're using, the scale of the sonographer, all that are some limitations of the ultrasound. But some of these limitations can actually be minimized. And that is one of the reasons why this training is being conducted. Yes, benefits and harms of ultrasound estimation.
Please round up.
I'm going to round up now. Yes, the potential harm is what I want to focus on, and that's changing EDD with successive scans. I'm sure you have all had cases in which the one will tell you that, oh, anytime I do a scan, the EDD changes. So we need to learn that we should not redate the pregnancy once we have an earlier scan that has dated the pregnancy. So avoid giving women different EDDs with successive ultrasounds. So recommendations, first trimester, use your CRL from either transabdominal or transvaginal. Second or third trimester, use a combination of parameters. If you have seen the one for the first time in the third trimester, you do a baseline scan and then follow-up scan in 2 weeks so that you can use that to estimate the age of the baby. And then when you have established your EDD by an accurate scan, you should not use subsequent scans to recalculate EDD, but rather the subsequent scan should be for growth monitoring. All right, so in conclusion, when performed with quality and precision, ultrasound is more accurate than a certain, in quotes, menstrual date, because we have seen that a lot of times that setting is very, very uncertain. And then after 23 weeks, you use your ultrasound or your clinical judgment. So thank you for listening. Any questions?
Thank you very much, Ma. So we'll take questions briefly before we'll call on Prof. Nabudozo to conclude. So if you have any question, just unmute yourself and ask. Okay, once again, thank you very much, Prof. We're grateful. Thank you for that lucid lecture.
You're welcome.
Prof. Nabudozo to continue with the basic ultrasound skill briefly for the next 10 minutes.
All right, thank you very much. And Professor Raji, we appreciate you a lot for your lecture. So I'll just quickly go through this. We stopped at this. Now we looked at this, and I remember the person whom we asked said she was not seeing anything. And the reason obviously why you're not seeing anything was because it was quite small. The same image, you can see it bigger, and then it becomes easier. What I actually wanted you to see were the fingers. So again, the same thing we talk about in ultrasound. Before now, many people will give you an image like this, and they're trying to measure certain things. But now we say no. So one of the things you must remember is optimization. Make it optimal. And those are among the things that you will have to learn in the course of the program. However, I want to thank you all for taking our time to attend the event today. Since the network today was, for many persons, much better than yesterday. However, we still have a good number of these lectures already in our systems. So they will be sharing the links with you so that you can go through them over and over again. The more times you go through them, the better for you, so that when we meet at the hands-on session, we would have gone through the lectures, and then it becomes easier and faster for us. So we'll keep sharing some of the videos that will help you